All righty, everybody. Thank you so much for joining us today. We are going to get started today with our very exciting webinar. We are hosting some of the hospital teams from ILPQC, and the topic is respectful maternity care, social determinants of health screening, and referral. Let's get started. First, a word from Dr. Sappenfield.
We want to welcome everybody. This is a new initiative for us. It's very different than what we've done in the past. And it was exciting at the kickoff, but we thought it would be very helpful for you to hear some hospitals who've been leading the way in actually doing this so that you can get a better vision of what this looks like and sounds like and how doable it is. And Illinois has been a sister collaborative for us since the very beginning. And we beg, borrow, and steal shamelessly from each other all the time. And our two speakers today come highly touted by our Illinois colleagues, and we thank you for taking the time to share your efforts there with our teams. You're in store for a big treat, guys.
Thanks, Bill. All right, hi, I'm Nicole Pellegrino. I'm the Senior QI Analyst for the Florida Perinatal Quality Collaborative. Thank you so much for joining us today. Let's get started, but first I did want to note the following. This session is being recorded. Keep yourselves muted, and then you can unmute towards the end during Q&A. We ask that you type your hospital name and your name into the chat. And then just wanted to note that we will be live tweeting today. So you can find us, I guess, at formerly Twitter, now X, but we have the same name, which is the FPQC. So our wonderful QI analyst, Sarah Steuben, will be posting some awesome information from the session today. The learning objective, the agenda is as following. We're gonna review the learning objectives quickly, introduce our speakers. Our ILPQC hospital team leads will be discussing their RMC and SDOH screening and referral efforts. And then there will be Q&A and conclusions and announcements. So here are the learning objectives. Today, our speakers will describe how teams are measuring and educating on respectful maternity care. They'll be summarizing how sister collaboratives, ILPQC, is implementing screening and referral, and then some discussion of how teams are engaging family advisors. So we wanted to note a little bit about our speakers today. The Birth Equity Initiative was launched by ILPQC in 2021. It's a little different than our Mother Focused Care Initiative. But there are some similarities. This is an important statewide quality improvement initiative for Illinois, supported by their Department of Health, their statewide quality council, and their perinatal advisory committee to engage hospital teams to implement strategies to address maternal health disparities and promote birth equity. Birth equity to them is the assurance of the conditions of optimal birth for all people with a willingness to address inequities in a sustained effort. While their initiative differs from ours a little in its aims, there are a lot of similarities that will be discussed today regarding social determinants of health, screening and referral, and respectful care. So I'd like to introduce our speakers. First up, we have Elena Jenkins, who is an RN BSN and the nurse manager of L&D at St. Mary's Hospital in St. Louis. And then we also have Laura Smith, who is BSN, RMCOB, and CEFM. She is a perinatal educator for OB services at Mercy Health in Rockford, Illinois. Thank you both for joining us today. So first, we're going to start with Elena. Elena, are you able to see, hear, and unmute?
Yes, I am.
Great. Do you want to take it away?
Sure thing. Sounds good. Alrighty. Like she said, my name is Elena Jenkins. I'm nurse manager for labor and delivery and birth equity team lead for St. Mary's Hospital in St. Louis. Next slide. So I apologize, we've got codes in the back. So the St. Mary's Hospital is a medium-sized hospital. We do approximately 2,600 deliveries per year. About 2/3 of our patients are Black and 1/3 are white. We have a really pretty high rate of severe maternal morbidities at our hospital that we see. We're a level 3 hospital and a perinatal administrative center for Southern Illinois. And our birth equity team started off very, very small. We just had a few nurse managers, community health worker, and staff member working on the initiative implementation. But the team has really grown over time. We've had much more, as we've had much more activities and presence, we got more buy-in and participation. And now we're able to collaborate with administration as well as system level patient experience and DEI leadership, which has been amazingly helpful. Next slide. So we really began our birth equity journey on social determinants of health. But before we began screening any of our patients, we really needed to provide resources to our patients, and we had no local resource list that was available. So this was our first big project. We created a resource list using a graduate student who was doing their project in coordination with social work to guide most of the most used resources, and created a handout with a QR code, as you can see there, that links to this online resource we could give patients. It lives online, so it can be regularly updated, which we do about every 6 to 8 months. And it has live links for patients to access actually based on their zip code. Next slide. So once these resources were created, we really needed to begin screening for the social determinants of health. And we had no screening tools to start off with. So while work was really happening on our system level in terms of social determinants of health screening, that took about 1.5 years to complete. So we needed to really expedite the process for ourselves to be able to determine our patients' needs and address them. We looked at a number of different options for validated screening tools, including paper forms for patients to complete. But the staff feedback was really that it would be too cumbersome in addition to the workflow to enter answers from paper copies. So the electronic health record really was the better integration for our workflow. So we petitioned to use the preliminary questionnaire that was already built into Epic, but not previously available for use. And we did the 4 areas of financial strain, transportation needs, housing stability, and food security, with these questions that you see here that are just really tailored to help identify the most significant and pressing needs of our patients. And then those were added to the electronic health record. Next slide. So when a patient screened positive, it flagged this concern present that you see under social determinants there. It was a navigator sidebar that was always visible, and it provided a constant flag to providers to show identified needs. They're able to hover over the words quickly just to see what the patient screened positive for and make sure that they were able to keep that in mind as they were creating their plans of care. Then in January of this year, CMS and Joint Commission Framework for Social Equity and Requirements to Reduce Healthcare Disparities had some new hospital requirements that took effect for our system that allowed our system level social determinants of health screening tools to go live. So with that, we now screen all patients on admission, and it is required documentation. So they have a full questionnaire that is integrated as part of the admission workflow. And that was also extended into our clinics, which had not been screening the same way before. So the clinics now screen at the initial OB appointment, around 28 weeks, as well as the first postpartum appointment, just so that we can capture needs that are changing throughout the perinatal period. Next slide. All right, so now we'll just talk a little bit about putting these pieces together and connecting to resources. Next slide. So initially in the clinics, we just provided this resource list that we had created if the patient screened positive. The really big challenge with this is that the needs in our clinics are very, very high, and the resource list requires work on the part of the patient. In our high and low risk clinics, we had no social work at all to be able, that was even hired part-time to be able to connect patients with services prenatally. So in really urgent cases, we would borrow a social worker from another clinic as a stopgap measure. But as this framework from CMS and Joint Commission took effect, this increased our administrative attention to the birth equity work and increased the resources. So from there, we have connected with a new platform that helps us to close the loops going forward. This platform is a great platform. Actually, it really has a robust list of resources, but it required a nurse navigator. And we had no FTE to act as a nurse navigator, like we didn't for social work in the clinic. So we got a little bit creative, and we have used a nurse that is on light duty to start her role as a nurse navigator so far, which has worked well. And then on the other side of this, we began a doula program pilot in our women's and infant substance health clinic, which is called WISH, with our patients that had some of the highest needs. This is a grant-funded program, and it provided free doula care to 40 families, included 3 prenatal visits, labor support, and then 3 postpartum visits. And what we really saw in this is that doulas were often able to identify additional needs and find resources that were really able to assist patients. So it provided more holistic care that was incredibly helpful. And that's been so successful that we have now applied for a grant to expand the doula program to all of our OB care clinics in the region. Next slide. I just wanted to show you that we've created a doula registry, and doulas are really made part of the care team. They have hospital orientations, receive badges. They're allowed to go wherever the patient goes as a member of the care team. And that includes even into our OR for emergency C-sections so that we can ensure that we are continuing the support for patients. Next slide. So we went live on June 28th with this new referral platform to connect patients with resources. So this data I just got yesterday, actually, it's kind of cool. Our patients are screened, as I said, at the designated intervals of first prenatal visit, 28 weeks, and then postpartum. And then physicians place an order to refer the patient for whatever needs they are screening positive for. So our nurse navigator contacts the patient, verifies the needs, and connects to agencies or nonprofits that is on the platform or off platform if the resources is not integrated into there. But over the last 1 month, from June 28th to July 28th, in 2 clinics, we had 43 clients that were referred for positive screening for a total of 113 cases. So each patient has an average of 2 to 3 cases, or like 1 case for each need, which really shows the complexity of the needs that we have right now. And there are currently 46 cases that are in process and fully connected with agencies that are actually working with the patient to address those needs. 14 cases are now closed. So totally in the first phase, first 30 days of this, hoping to really be able to see much more in the next 90 days as we're starting to get some more reports back. Next slide. On the inpatient side of things, initially we just had 1 social worker for all of women's services. So you can imagine that caseload. And we have an incredible social worker, but the increased referrals just really justified hiring more social workers to cover the patients that are needing to be seen. We've gotten some updates with the CMS and Joint Commission framework so that we now have a banner to create a bold reminder to frontline nursing staff just to place referrals to social services. They're able to really enter the specific reasons for the referrals that makes it much easier for social workers to prepare to see the patient. And it really creates this more automated process so that fewer patients are slipping through the cracks without the needed contacts on the inpatient side. Next slide. Another method that we are using to refer patients that have highest needs is a home visiting program with a partner organization. So we are identifying the highest needs patients on our inpatient service, enrolling them in the home visiting program. And then this program provides access to medical and mental health support, supportive health and parenting education, peer support, material support like diapers, gas cards, those things, and then follows these patients throughout their pregnancy and up to 2 years of the infant's life. So it's going to be incredibly helpful for these patients. Next slide. We have also integrated our social determinants of health screenings into our formal QI review process. So bi-monthly, we have a multidisciplinary team of the group that you see there: OB and neonatal, nursing leadership, anesthesia, perinatal outreach, and quality improvement. And we list this information on each trigger sheet so that as we review each case, we can track how these factors may have affected care or the outcome, so that we can really do some process improvement and find opportunities to better coordinate care. Next slide. And then lastly, on the community-based side, we've created a really large program now. They're called moms groups. They are peer-led support groups for expecting and postpartum moms. This provides mental health support for perinatal mood and anxiety disorders, or just support as new parents and moms who are expecting. There's material support, again, diapers, childcare, gas cards, and we have multiple locations throughout the region to be able to serve the various neighborhoods. So it's been incredibly helpful for those parents. Next slide. So I'm going to transition a little bit to our respectful care side of things. We initially put up posters of our respectful care practices and our commitments to our patients throughout labor and delivery in all of our clinics. It's in every single room so that every patient is really aware of the commitment that we have for respectful care. And then once the patients are getting ready to be discharged on postpartum, we have introduced the PREM survey, or Patient Reported Experiences Measure survey. When we first rolled this out, we had less than 1% participation in the first 3 months. And we figured out that that was because we had the incorrect QR code on handouts. So good finding there. We really also, in addition to that, just kind of had low nurse education and participation, or really motivation to get going with this. So we had to revamp. Another challenge was really that when patients were actually able to get the correct QR code, there was really a lack of access on the phones. The way that it looked on the screen, the small screen, just looked like a very long questionnaire. So people were not as motivated to get into that survey. Next slide. So we changed the mode of access as we revamped this. We used iPads that had previously been used for COVID and repurposed them so that we put them on stands, brought them in the room just before discharge for all patients to be able to see in a much larger format. Makes the survey look much shorter. We track this on performance boards. So essentially, every single day, we list the patients that are going to be discharged, and then the nurses can go and check off when they have completed the PREM survey. So that really just gave that kind of visual accountability. We re-educated nursing staff, and then brought in nursing students that were adopting this project. So they analyzed what we had done, created some further education for the nurses and promotional materials for their go live, and followed up with initiating survey participation with patients as well, and further education for nursing staff. So that was extremely helpful for them and a fun project. Next slide. So in analyzing this, we had these initial challenges in adoption, but we've gotten a great deal better. We have started sharing our results at our OB operations meetings, at all the staff meetings, and it really has driven a number of process changes. We increased participation significantly, and so now we are at about a 30 to 40% completion rate, which is awesome. We've gotten a lot of good data. We just held a large event with the second largest hospital system in our region and a community organization to discuss with patients what respectful care looks like and how we can improve on our respectful care. And our plan is to start a newsletter that provides this information and disseminates it more widely to staff and providers so that we can really keep up with what are our patients saying and what does that mean. Next slide. The biggest areas that we have made changes in analyzing the PREM survey and bringing it to staff and our OB operations meetings were a couple of different strategies. The commit to sit strategy, team discussions, debriefs, and education. So initially there was this hesitancy to believe disparities in the results, but repeating the results, as we were going over the results in each of these meetings kind of showed everyone that there was a need for practice change. So commit to sit is really, the nurses constitute the majority of health-related interactions with patients. And studies show that sitting down and connecting with patients really fosters relationships and shows compassionate care. You connect with patients and there's much more of a feeling of being heard. So we've initiated that with all of the nursing staff so that every single shift, every nurse is expected to have at least one session of sitting down at the patient's eye level and having that conversation. Could be anywhere from 90 seconds on up, however long they decide to speak with the patient. That has really increased the perception of being heard in our results. So that's showing some positive benefit. We have increased our team discussions so that essentially every time that a physician goes in the room, the nurse goes in the room with the physician so that we all are on the same page. It's a group discussion. It improves shared decision making, includes the patient and the family in all of the plan of care so that everyone feels like we have a shared understanding. And then we've reinstated debriefs that includes patients post-emergency situations, so post-crash C-section or hemorrhage or any of those things, so that, again, everyone has that shared communication, shared understanding of what is happening so the patient feels more part of their care. We've also been working on grand rounds presentations to reach all of the physicians on trauma-centered clinical practice, patient-centered communication, integrating community engagement initiatives into prenatal care spaces. So we're really starting to see our results moving in the right direction. And that's my thanks.
Thank you so much, Elena. We're going to move on to Laura now. Laura Smith, the OB educator with Mercy Health, Rockford. Thank you so much for joining us, Laura.
Can you hear me?
Yes.
All right, great. Worried about that part. Hi, thank you for having me. Yes, my name is Laura Smith, and I'm the OB educator at Javon Bay Hospital. Next slide. Javon Bay Hospital is the perinatal center for Northern Illinois. We oversee 11 surrounding counties, and we do about 900 deliveries annually. We are not our patients are not very diverse. We have about 75% white patients and about 80% have private insurance. So our birth equity team actually is a little different than Elena's. We had a huge buy-in right from the get-go. A lot of staff were really interested in being a part of this group. So we have team members from the OB physicians, MFM, and we have one certified nurse midwife. Our director is involved, our OB manager. We have nurses from the outpatient clinic and the manager as well, and then nurses from inpatient. We have case management on board. We brought in an IT specialist, and we also have a nurse navigator. Next slide. So we launched our initiative in April of 2022. Our first step was to start implementing education and getting our resource mapping tool. We wanted to build our resource mapping tool before we started screening for SDOH, which took us some time. We didn't want to screen a patient positive and then not have the resources in place to be able to refer them to. And then we launched our screening and our PREM survey all at once in December of 2022. Right. So I'm going to briefly touch on social determinants of health. Elena spoke a lot about this, but I'll just tell you some of our differences. This is what our screening tool looks like. We hand the patients a paper form, and we found that them filling out a paper form, they are more honest, and it's a little less time consuming for the nurses. So they go through and fill it out, and then the questions mirror exactly of how it's built into the EMR. So we built a SDOH screening tool into the Triage Admission Navigator. It did exist before we did this, but it was harder for the nurses to find. So this way, when they're going through their questions that they always have to ask for both the clinic and inpatient, they can easily go through and answer them, and they go in order of the questions, so it makes it easier to chart. Next slide. And then what I found, it was really helpful for me when I was doing data tracking, when I look in the social determinants of health through the triage admission, I can see exactly when the patient was screened. So this patient, for example, she was screened on admission in July, and then I can go back and see she was initially screened in January at her first prenatal appointment, and then in May. And this patient's answers didn't change, but sometimes they're positive. What I'd like to see is they're positive initially, and then by the time they come inpatient, I have had some negatives because we've met their needs and sent them to resources. Next slide. So we've discovered a barrier for the clinic to be able to document when resources are given. In the clinic setting, they don't always print AVS. So when I was looking through and we're trying to track what happens to these patients that screen positive, it was very difficult. So we built this SDOH notes section, and it's right after the screening. So when they screen positive, they can click right into here, create a note, and we built a smart phrase that is the SDOH screening. All their answers will flow into it, and then it has a drop box for the nurses to identify and chart which resources they gave them. In the clinic, they would hand paper resources compared to in the inpatient where we have the AVS that we print off. So here's an example of our resources. We built them into the EMR based on which detriment by quick category. So it makes it really easy for the nurses when they screen positive. They just put the smart phrase in, SDOH-OB, and then they come up in an alphabetical order in English and Spanish. And then when they open it up, I think it will show on my next slide, just an example of what it looks like. So that will pop into their discharge AVS, and then we do follow up with social services, and also our OB navigator is involved in these, but this way we can get it into their chart. And then in the clinic, as I said, they would hand them the forms based on the needs. Next slide. Okay, so I'm gonna jump to respectful care. And I just wanted to show you here is on the left is the Illinois strategies compared to the Florida strategies. So number 4 and 6 really are very similar as far as sharing respectful care practices and our goals across the states. The big difference I noticed here is in Illinois, we focus a lot on respectful care education and then addressing implicit bias, where there's a little bit of a difference. So you'll see that as I go forward with how we tackled that here in Illinois. So this is our commitment to respectful care. I put them side by side of Illinois compared to Florida's. I kind of dug through this, and the wording is almost exactly the same, which was kind of cool to see. One thing I really liked about Florida's is I can't find it right now, but you, in Florida, you address the support person, which I thought was really cool, and include them. Oh, number 4, welcoming the support person and treating them with respect too. Next slide. So when I went about educating staff in respectful care and bias, this was probably the hardest part of this initiative because telling healthcare providers who are in the field of caring for patients that we need to improve on how we treat patients just wasn't received well, as you might understand. Even myself, if you told me I needed to be more respectful as a nurse, I would not like that very much at first. So it was very difficult to launch education and get buy-in from the staff. For one thing, respectful care is very subjective to how we receive respect and how we show respect. It's based on the patient's perceptions, on the staff perceptions. Our work environment can affect our ability to give respect at all times, our patient load, our psychological and physical needs. If I haven't gone to the bathroom, I've been in the OR all day, I'm starving, and now I'm going to go over here and show respect. And so it's really about presenting it in multiple different ways to the staff is how I've had some success. So next slide. I had to get very creative with buy-in. I had lots of nurses rolling their eyes when we would talk about it at the nurses station, about the initiative and how it's going. I did have a physician tell me he was very offended by some of the education he had to do, but I kept at it and just tried to find different creative ways to present the education. So we would do case reviews and staff meetings based on what patients said, what their survey results are. I do have a monthly newsletter I offer to staff that I offer contact hours for. So I get a lot of buy-in with doing the newsletter because they want those contact hours. So each month I would put just changing it up. So here's some examples here of different ways I presented respectful care. I would have YouTube videos of patient stories, sharing patient feedback. We do safety huddles every day. So if there was problems with the patient, we would reiterate with the staff the respectful care component. And then as we started getting our PREM results, I'm able to use the survey results to drive further education. Next slide. So when we began the respectful care education and implicit bias, we have that caveat there in Illinois. We started out by making it anonymous. We just wanted it to be fun. We didn't want to force staff to take part in bias education. We offered a gift card. Everybody took this Harvard implicit bias test, and the results are completely anonymous. They just needed to send in their name that they took the test, and then we did a drawing for a gift card. So we did that across inpatient and outpatient, and quite a few people participated, but we needed to move forward with 100% compliance for education on respectful care. So eventually, through Illinois, I was able to download online modules into our learning platform in the hospital. So that was really easy because I could just assign it, and they didn't know it was assigned by me. It just looks like it's assigned by the hospital as part of their criteria. That is when I got feedback that it was very offensive, but some really, really liked it. So we were able to gain 100% buy-in for that. Next slide. Another thing we did for respectful care was an aftershock viewing event. So just going along with multiple different approaches. Aftershock is a Hulu documentary, patient stories with poor outcomes, and they tell the story of their experience, how they perceived their healthcare providers. And it's really powerful, really moving. It does incorporate the diversity aspect into the documentary, which is a big push in Illinois. So it was free, we had contact hours. brought everyone together for dinner and watched the documentary. And then I had a post-panel discussion with 2 MFM providers, an OB, and then a certified nurse midwife. So from this event, it was medical professionals only, an OB invited from our region. And then from there, this event launched to medical schools and then eventually to the community. We kind of started slow, and there we've had several events since then. Moving forward. Another way to get buy-in for respectful care is we highlighted each one. We had respectful care of the month. So this was an example. This month it was respectful care of the month was number 3, learning patient goals for delivery and postpartum. So we would post this on the unit. We would discuss it throughout the month. It would be highlighted in the newsletters. So just to get the nurses used to each of these components that are in those practices. Next slide. So we took, similar to what Elena said, we took our posters, our commitments to respectful care. We had them blown up into big poster size and put in all of our patient rooms in the hospital, and then they are also put in the clinics for patients to be able to visualize. We put our respectful care practices in patient folders, so when they are their first prenatal appointment, they would get a printout of what respectful care means to us, what they can expect during their care, and then they would also get a handout when they were admitted to L&D. I did have all the nurses sign the commitment. I did see that you have that in Florida as well. You know, they sign the paper and it goes in their file and they don't give it much thought, but I tried to sit each one down during validations or simulations and say, by signing this, you're committing to treating every patient with respect. And then our prenatal classes that we offer to the community, they also go over the respectful care practices that they can expect. Next slide. We also had Birth Equity Apparel. Birth Equity is the name for our initiative here in Illinois. We created t-shirts that we sold that did really well to the clinics and nursing staff. And then we also made buttons to just kind of represent birth equity and get buy-in across the staff. Next slide. So moving on to our PREM survey. When we launched our PREM survey, it stands for Patient Reported Experience Measure. And this is the survey that they received before their discharge to answer questions on how they felt about being respected. When we launched this, this is some of the education I did, kind of coaching the nurses on the scripting and saying the key words. So I could take part in decisions about my care, saying throughout their hospital stay, I want you to feel included in your care, keywords like that. I felt pressured by the team into accepting care I did not want to receive or did not understand. And for the nurses and the staff, I want to ensure you understand the plan and agree to proceed. So this goes along with survey studies where saying keywords, patients might not remember that they were treated with respect, but when we speak in that lingo throughout their care, then the questions are asked, then they realize, oh yeah, they did say it that way. So that was part of the education we did there. Moving forward. When we started, we created these laminated cards similar to what Elena showed. We had English on the front and Spanish on the back, and it was hooked right here, if you can see in this picture, to the scripting for the nurses as it was new for them. They would go in, have the patient scan, and complete the survey. We also have an OB navigator, so it was heavily put on her task role to complete that on discharge. Next slide. This is an example of our scripting we had for the nurses when they dropped off the card. And then we built it into the EMR, whether the PREM was completed, yes or no. It says Illinois only because we are affiliated with some Wisconsin hospitals, so our EMRs mirror theirs. So this made it really easy for us to look back and see how often the PREM is being completed, and then also like see if it's certain nurses or certain time of day, that along with the charting. So this is our completion rate. We started out really well. As I said, we launched in December of 22. So that 39% doesn't reflect the entire month. And then we did great. Our results skyrocketed, and you can see we've just slowly gone down from there. So what we are in the process of doing now is switching the survey to have our birth certificators, certifiers, do the survey with them. So we figured every patient needs a birth certificate, and there's only a select few that go through with the patients to do their birth certificates. So that means holding just 4 or 5 people accountable to make sure they're getting the PREM survey. So we're in the process of doing that now. So I'm hoping by next month we'll see this number start increasing. We also tried to do the iPad. We've heard of some success with other hospitals where if they pull up the survey with the QR code before going into the room and then hand them the iPad to complete the survey, was very successful compared to having them take their phone and scan the QR code. Our problem here is our iPads are old and they don't support the app, so we have to work on fixing that before we can do that. Next slide. So this is an example of what our results look like. In Illinois, the results are categorized by race. And this, I think when I screenshot this, this was our overall. So in the last 6 months, this is what the patients are answering. So it looks kind of like that, and then you can break it down to months. So you can see, now I can see where we have room for improvement, which is really helping with education and also with the staff buy-in. Next slide. Okay, so future opportunities for us, we do want to implement that iPad for the PREM survey. And then I mentioned this in the discharge checklist that we chart whether the PREM was completed, and we want to add if the patient refused in here so that we know maybe was it just not offered or did the patient actually refuse. And then now that I have results from the PREM survey, what patients are actually saying, we can move forward with more education. So when I present it to the staff, they can see this is what the nurses are actually saying about their care. And then we are still working on engaging the community in our QI efforts.
All righty, thank you so much, Elena and Laura. We are going to move on to our Q&A now. So I am going to stop sharing and we are going to check out the chat. Looks like there's plenty here. But go ahead and unmute yourself and feel free to turn on your camera if you have any questions. Chat is also fine.
Nicole, one asked if they would share their quality improvement trigger form, that we would love to see what that form looks like.
Absolutely.
We can share that.
Great. All righty, well, I have a question for you. So in your respectful care trainings, can you just speak a little bit more on, if possible, sort of what the resistance was there? Was it to the notion that respectful care wasn't being provided? Was it the notion that they might be biased in some way? Was it, do you kind of have a little bit more of a specific idea of what it was that people were sort of resistant to?
Yeah, what they were resistant to was accepting or acknowledging that they had an area to improve in, that they needed to improve on their respectful care. So as healthcare providers, they feel like they do treat their patients with respect, and they do treat everyone equally. And we don't have bias. We have great outcomes no matter the race, because we have the diversity component here in Illinois. And so accepting and acknowledging that this was something they needed to even learn and improve on was difficult.
Thank you for that. Elena, did you have any pushback on your education? And
We used diversity science modules, which has a really great program that staff can go through. I didn't actually get any pushback on those modules, but there was another DEI focused webinar that was hospital based that we did get some pushback on. Again, just questions from staff in terms of why we needed to learn this. We already treat everybody equally. So there was just a lack of recognition of the fact that there is sometimes bias in healthcare, and that can really make a difference in how patients are treated. So there was some pushback on that, and we just pivoted.
oh, Elena, I think we lost you for a second. All righty. I do see some hands up. Lindsay Greenfield, did you want to unmute yourself?
Hi, yeah, this is, I hope Elena didn't leave. This was in reference to her social determinant screening. You talked about how it used to be paper form and then you mimicked into your EMR system. I know that like CMS requirements and stuff are moving towards like all patients now across the board when you work with Medicaid, Medicare have to be screened. Is that specific to your nurses screening, or do you work with the admissions department and other specialties like casework or anybody else that screens any parts of those questions? That's what we're trying to deal with now, of who would be assigned and how often you're screening. So for example, some of them are like in the last 12 months, it states certain things. Do you literally ask it on every admission or every visit to the hospital, or do you only ask it as it flags within a 12-month time frame?
Great question. So we definitely made this. Okay, so on the inpatient side of things, this is a nursing task. On the inpatient side, it is done on every single admission or encounter, including in maternal triage. Whereas on the clinic side of things, it is again a nursing task, but it is asked at the certain points in time on the initial prenatal visit, the 28 weeks, and then the initial postpartum visit. So it has not been, there have not been any other departments that have been involved in that screening. The only thing that we really required from another department, which was admitting, was to ensure that they were asking the correct questions in terms of having the patient self-identify their race.
Perfect. Thank you so much.
And if I could add, we do the very similar. The nurses inpatient and in the clinics do the SDOH screening, and it's at their first prenatal appointment, 28 weeks, just like Elena said, and then we only screen when they're admitted to the hospital, so it will be with all their consents. We don't screen every time they come in for a triage. And then ours includes, at the top, I didn't show it, but they're a spot for them to identify their pronouns and their race and ethnicity, which is usually documented by admitting, but if they've changed it or if it's inaccurate, then the nurses can go in and fix it.
Thank you. Margie.
Thank you. Ooh, sorry, I have one more. Can I ask one more? Just wanted to ask, can you guys share your policy on doulas, or is there a way that we can get that resource afterwards? There was a whole like doula paper that talked about that resource one. Is there a way that I can be shared with afterwards?
I'm sure
specifically if you have doulas in the OR.
We do. It's more of a guideline. We do not have a specific policy written. We just have shared with all of our teams that doulas are a part of the care team, and therefore they are welcome to be in the OR or any other space that the patient is in, just like one of the, nursing or anesthesia staff would be able to be present at that time. So there's not something specifically that we wrote in any sort of policy or guideline.
Okay, thanks.
Great. Next, we have Margie has her hand.
Yeah, thank you so much. I'm echoing. Can you hear yourself? Sorry, I'm in there with Estefania. Sorry for sharing office today. It was such a good presentation. Thank you so much, Laura and Elaine. It was good to see you at National A1 sharing your knowledge. Thank you so much. And I love the scripting. I think what you talked about, sometimes people, little resistance here and there, especially, we did the same thing with our patient experience in Press Ganey. So I love the scripting idea, and I'm going to take that back to the teams as well. So I just wanted to say thank you so much. This has just been an incredible webinar. Thank you. I see a lot of the teams out there. Thank you.
Thanks.
I see Bill and Ben have their hands up. So whoever wanted to go first. Bill?
This is Shaminka Greenidge and Lynette back from Health Park with Lee Health. Ben sent me the link because the original link wasn't working. So I think when I raised my hand, it showed as if I was Ben, but this is Shaminka and Lynette, just to clarify.
Okay.
In regards to our respectful maternal care, we did present that at our providers meeting on July 26th, and we had our State of the Union last night. We're having another one tonight. So we did plant the seed in terms of the requirement for 80% compliance by December of next year, that all nurses and providers have that. Our question is this: what resources do you suggest we look at to obtain that education? There's certain things we're looking at. Health Park is huge, so we have a ton. We have hundreds of nurses here just for OB, and a ton of providers from at least 5 different provider groups. So of course, cost is something at the top of our minds. So are there any resources that are cost effective to obtain this respectful maternal care training that you could suggest?
We had, through ILPQC, there were lots of resources offered to hospitals in the region. As Elena mentioned, Diversity Science, we also used that because it was free, and it was really easy to download. It had multiple components to it if you wanted to use it, and then I was able to just upload it into the PLC. We also had seminars through our Quality Collaborative Speak Up training. So some of the stuff I put in my newsletter was from Speak Up training, which was made free to us. And then a Hear Her campaign that we've had education on. So through the state, we have multiple things, and I could share some of those things with you or with Nicole to go through. But
Thank you. If you could, yes, absolutely. We would love to get the ball rolling. We have hundreds of people here, so it's going to take a lot of time. So we wanted to get a jump start on that.
I did want to note really quick, I'm sorry, I see Bill has his hand up. I did want to note really quick that we are developing some respectful maternity care trainings. FPQC is, and we'll be hosting, we believe, 4 of them this fall. We'll be including, actually on our website now in our toolbox, there is, we've made a list of recommended key, suggested key components of RMC training. So teams would be able to go and seek out trainings that sort of check those boxes, but our training will sort of be custom tailored to the initiative and really have that focus on respectful care and things germane to the MFC initiative. Bill, did you want to say something?
Before I do, Colleen Rodriguez had a question. She wanted to know who was employing the doulas that you were using, Alina?
Sure. So we actually partnered with a nonprofit that handles all of the doula onboarding and payment. So through our grant program, that's where the money is funneled through. They handle all of that to get the doulas paid. So essentially, we just have a use agreement, with the nonprofit and the doulas, so that they're kind of like independent contractors with the hospital, so the hospital does not pay them directly. And then we just treat them as volunteers in terms of the hospital orientation and badges and the like.
Thank you. And my question is, many of the hospitals now are starting their initiatives. Thinking back and what you know now, what key 2 or 3 things would you recommend that they do getting started that you wish you would have done when you got started?
For me, I would have implemented the survey right off the bat. I would have tackled that first, start getting the patient feedback before, then I would have before and after all the education we've done as well. But starting to get that patient feedback right away, working out the kinks of that would have been one thing would have changed.
And I think on our level, I mean, we've done so many different things in this journey in such a short period of time, but I think one of the most incredibly helpful things was to actually get patients together and hear from them about our process. So we just had this event with a number of patients where we talked about the respectful care practices commitments that we have made, and then is this what respectful care looks like to you, and in what ways can we show up better? And then the other thing is, I think that the scripting that Laura shared may have been something that would be much more helpful for us to begin in the beginning, because one of the survey questions on the PREM survey that we had the most challenge with was patients feeling pressured into care, and then that we were not explaining care as well when we were not able to meet their wishes. And so I think some of that scripting for staff to be able to kind of help with that from the beginning would have been more helpful.
Well, thank you for taking your time to do this. Nicole.
Yep. Thank you so much. I am going to just really quickly share this. Sorry, guys. Alrighty. I want to thank you all for attending today. This was an amazing webinar and right on the hour, so that's awesome. Just want to remind you that our toolbox can be found at fpqc.org/MFC. The toolbox is in there. The recordings from today and slides from today should be up by tomorrow, early next week at the latest. You can, of course, email us for any information that you would like to request from the webinar today. And then following us on all those fun social media platforms that you see right there would be great. Stay tuned for our e-bulletins and e-blasts that come out regularly. And I'm sure we'll be discussing this webinar on our upcoming coaching calls, so be sure to check your inboxes for those. So on behalf of FPQC, I did want to say thank you so much to Elena and to Laura for giving us your time today. This was amazingly informative. And thank you to everybody else for attending today. Have a great one.
Thank you. Good luck to you all.